My name is Miriam Galindo, and I want to welcome you today to my presentation on ethnomedicine in palliative care. In the United States, where Western biomedicine is predominant, health is defined as the absence of disease or dysfunction. This view focuses on the physical, but does not include psychosocial or spiritual well-being. In sharp contrast, non-Western perspectives on disease tend to include psychosocial and spiritual, as well as physical dimensions. Incorporating the latter into 21st century palliative care is what we will talk about today. At the conclusion of this PowerPoint, the viewer should accomplish the following: acquire a definition of ethnomedicine, understand the connection of mind, body, and spirit in patient care, recognize Roy's adaptive model as a nursing theory supporting ethnomedicine, articulate the applicability of ethnomedicine to palliative care, and finally, integrate ethnomedicine as a viable part of nursing practice in the U.S. healthcare system. So let's start with the definition of ethnomedicine. What is it? Well, ethnomedicine is defined as a comparative study of cultural ideas about wellness. In other words, how illness is defined, the etiology of disease, and how it is treated. As such, ethnomedicine promotes the understanding that mind, body, and spirit cannot be treated separately. In other words, health is the result of a singular body force or bioenergy. The aim in ethnomedicine is to prevent diseases rather than just focusing on a cure. And the treatment can range from food, herbs, spices, exercise, massages, and acupuncture to a host of other things. The main concept in ethnomedicine emerges from a holistic view that people are mind, body, and spirit in constant interaction with a uniquely experienced internal and external host of factors. This means that it's not enough to send someone to a psychologist for mental problems, or a physician for body problems, or a chaplain for spiritual problems. In fact, in ethnomedicine, healing for mental disorders might occur through physical interventions, and health for physical or mental disorders may come through spiritual interventions. In fact, problems with health can be the result of cultural issues or even cultural barriers. Even now, by the way, research is affirming this mind, body, and spirit connection and promoting this idea that they're intimately and inextricably connected through neurological, endocrinological, and immunological pathways. The etiology of illness is also really important in ethnomedicine. We're familiar with biomedicine, and it is practiced predominantly here in the Western world. In this philosophy of diagnosis, we're looking at one way of diagnosing and treating illnesses, and that's truly the applicability of chemistry and biology. Um, but in other cultures, there might be an etiology that's emotionalistic, naturalistic, or personalistic. The emotionalistic source suggests that emotions or psychological causes may predispose a person to illness. For example, in Latin American countries, there's a condition called susto, which is a culture-bound syndrome, meaning you see it in certain cultures, but you may not see it in other cultures. The way it's understood is that it results from a spiritual attack, and truly it looks a lot like our PTSD, in that it often occurs after a frightening event. But look at the symptoms, which really take into account that mind, body, and spirit. Symptoms includes nervousness, anorexia, insomnia, listlessness, fever, that terror that is described in the diagnosis itself, depression, and diarrhea. So there is this mind, body, and spirit. Treatment involves prayer, healing rituals, massage, and the use of plants as medicine. Look at the other etiologies, naturalistic and personalistic. Naturalistic causes include aspects of nature which disrupt body elements. These elements can range from thunder, lightning, drafts, to even excessive stress, and food and drug incompatibility, infections, or family susceptibility. The best way to think about naturalistic illnesses is that they're caused by chance. By contrast, personalistic etiologies refer to the cause as someone rather than something, someone rather than something. And instead of it occurring by chance, it's caused by intention or for a greater purpose. In this perspective, there are no accidents and no coincidences. And the cause can be a person, like a witch, or it can be non-human, like a demonic spirit or a ghost or an ancestor, or it can be caused by a supernatural deity. Incidentally, it is very rare that you get personalistic or naturalistic causes. Typically, what you get is a combination of both. Either, it could be caused by naturalistic or chance, or it could be caused intentionally by a personalistic cause. So usually they're considered together. So for this assignment, we were asked to apply this concept to a health issue. And the health issue that I chose is palliative care because I see ethnomedicine as truly amenable to palliative care. Palliative care, as you know, is not necessarily equivalent to hospice. They can be considered distinct. Palliative care is simply maximizing a person's quality of life while minimizing suffering of the patient who is struggling with a serious chronic and possibly, but not always, an incurable disease. During these times when physical health is no longer something for which this patient can take for granted, spiritual and religious beliefs strongly influence the course of action. At these points, I feel a patient, and researchers corroborate, that patients yearn for meaning, purpose, forgiveness, acceptance, and peace, among other intangible concepts. The following quote fully captures what we're talking about when we think of mind, body, and spirit. And this is a quote contributed to the literature by a doctor back in 1910 who observed that it wasn't just a treatment of the body that led to a cure, but something intangible that happened in between. And he defined it as faith. And the way he described it is it could be faith in the gods, it could be faith in the saints, it could be faith in little pills, it could be faith in suggestion, or simply that you have faith in the doctor. But there's something that's intangible that causes a person who is bedridden to get up from their bed and walk. And that's what we're talking about with this mind, body, and spirit. It's not just about the medicine. There's something else going on. So that leads us to a theory that fully captures what we're talking about. And the theory that I chose, which really I think supports ethnomedicine, is Roy's adaptive model. Sister Callista Roy, as you know, has this impressive professional resume. But what few people know is that Sister Roy herself struggled with an illness that left her bedridden and forced her to take a leave of absence from school and from her beloved workplace. And that was a disease of encephalitis. And it took quite a long time before she was able to go back. Her theory was changed the course of the direction of a lot of medicine because it connected this mind, body, and spirit. And so let's look at central themes of this theory here. First of all, it's a holistic theory. It doesn't just see people as biological entities, but rather as biopsychosocial and spiritual beings in constant interaction with a changing environment. Wellness, then, is not simply a freedom from disease or death, but rather a person's ability to adapt to circumstances. It's the adaptation, not the circumstances, that lead to integrity and wholeness. Let's say this differently. You can be dying and be whole at the same time. In other words, you can be dying and well at the same time. And that's what makes this theory so applicable to what the topic of this discussion is. Here's another way to look at it. The goal of medicine, the goal of healing, is to establish a psychic or spiritual integrity. I need to know who I am to exist with a sense of unity, meaning, and purpose in the universe. That's wellness. And so what nursing is expected to do in ethnomedicine is to promote adaptation of the person, health, and environment interaction. We are expected to promote quality of life despite the circumstances. And if the person is dying, that we're promoting dying with dignity, that we can, in this greater concept of understanding, promote wellnesses within dying and within chronic illness. So let's talk about the spiritual assessment when it comes to applying Roy's model and ethnomedicine to palliative care. Well, the End of Life Nursing Education Consortium promotes patient autonomy in making healthcare decisions about one's unique journey through illness and death. And the best way to promote this is by having a conversation. Talking about things like this are not just limited to physiological considerations like, do you want CPR or not, which is our standard understanding of advanced directives. Rather, the conversation needs to be about things that matter holistically and that promote psychosocial aspects like the reduction of guilt, the reduction of stress, anxiety, depression in both family members as well as patients. The nursing actions that promote this are critical in establishing goals for treatment. And if you notice, these goals are not necessarily just about the physical. Look at this acronym here that I found, VALUE, V-A-L-U-E. The V is focused on valuing what family members are saying. The A is about acknowledging emotions. This certainly sounds psychological, doesn't it, so far? The third, L, stands for listening. U stands for understanding what the person is saying, and not just the patient, but the family too. And E is about evaluating. And evaluating also includes modifying those evaluations, so constantly changing that treatment plan according to what the patient is needing. So when we look at the possibility of finding a standardized method of measuring optimal patient outcomes, I found something that does promote that, and that's the End of Life Decision Making Guide that was developed by Annette Browning, Dr. Annette Browning, who now goes by Dr. Callis. She is a former professor of mine and devoted her life and her research to these concepts. This standardized measure is not necessarily validated or generalizable, but it's certainly emerging in a concept that can be applied to situations like this and lends itself to further research in the future. So this acronym guide can apply to the steps that we take in asking questions that promote a conversation. And she gives a 2-page guide, so to speak, or conversation tool with questions attached. But these questions correspond with this acronym. So G corresponds with gathering data and identifying any dilemmas. U is about utilizing resources and identifying the ethical and spiritual problems therein. I is about informing the patient and family of treatment options, the risks, the benefits, and the alternatives. D is for documenting decisions and giving a rationale. And E is about evaluating and modifying the plan of care. Here's an example from her two-page set of questions. And I want you to notice how much she's incorporating this mind, body, and spirit interaction. It's not just about asking the standard questions for advanced directives. So look at this first question. Would the patient rather consider death than be on life support for an undetermined period of time? Well, that's a good start in talking about the body. But look at the direction of that question. Would the patient rather consider? Then look at the fourth question down. Do you feel, and in what ways, are you overwhelmed in taking on the responsibility of life support and end-of-life choices? Doesn't that sound like a relational or psychosocial question? Because you're not just considering the person in isolation, you're considering that person within the context of relationships with others. And then this next beautiful question, are you feeling guilty? That's a feeling question. That's an emotional question. And then this open-ended question to follow, other emotions. Let's talk about everything. Let's bring out the anger, the sense of injustice. Let's bring out guilt. Let's bring out ambivalence. Let's bring out depression. Let's bring out, going between anger and sadness and helplessness and vulnerability. All of these can be discussed. And then look at this wonderful last question. How can you apply your beliefs and faiths to this situation? So Dr. Browning has integrated this mind, body, and spirit in her wonderful questionnaire that we nurses can use to guide us in asking questions to promote a conversation that fills in the gaps of advanced directives when we're talking about end-of-life decisions or even chronic illness. So what's the impact on advanced nursing practice and within the U.S. healthcare system in particular? Well, in the traditional understanding of hospice and palliative care, we do have the advanced directive, but as you know, advanced directive focuses on treatment wishes for the body only, for the most part. Standardized measures to assess spiritual concerns surrounding illness and death remind us that nurses need to view patients as a whole, body, mind, and spirit, when developing goals of care. So nurses committed to ethnomedicine also view people holistically. They are, in fact, holistic nurses. And we holistic nurses attend to the whole person, body, mind, and spirit, in terms of emotions, beliefs, and goals of care. That puts the onus of responsibility on us nurses to make sure that we're educated and we receive experience in the psychological, cultural, social, emotional, and spiritual aspects of patient care, as well as the care of his or her family, because the patient does not exist in a vacuum. The patient exists within the context of relationships that pull for both cultural, emotional, and relational interactions, and that's in constant flux. So ethnomedicine, by definition, relies on a broad, holistic understanding of this patient and his or her family. For more information on this subject, I encourage you to peruse these references because they give you not only a good sense of what we're talking about when we talk about ethnomedicine and how to view patients within a holistic lens to consider diagnostic criteria, but also treatment aspects, because when we're considering holistic treatment, we're considering mind, body, and spirit as well. As I said before, that considerations of physical maladies may be amenable to things like spiritual interventions or psychological interventions, and vice versa. Thank you for your time, and be well.